Welcome to StudyNeuro. In this lecture, we'll explore brachial plexus injuries with a clear focus on how they're diagnosed and managed in clinical practice. We'll start with a brief review of the relevant anatomy, then move through the common causes and mechanisms of injury. From there, we'll look at how these injuries are classified, evaluated, and investigated before discussing treatment options, rehabilitation strategies, and expected outcomes. By the end of this session, you'll have a structured, practical understanding of brachial plexus injuries and how to approach them from diagnosis through recovery. For more in-depth lectures and clinical insights, be sure to follow StudyNeuro on YouTube. The brachial plexus is a complex network of nerves formed by the ventral rami of C5 to T1. It coordinates both movement and sensation in the shoulders, arms, and upper chest. When these nerves are injured or affected by disease, patients may experience pain, numbness, or significant weakness. A solid understanding of this anatomy is essential for guiding treatment, planning rehabilitation, and optimizing patient care. The brachial plexus starts with the roots from C5 to T1, which merge to form the superior, middle, and inferior trunks. Each trunk then splits into anterior and posterior divisions, which regroup into three cords: lateral, posterior, and medial. Finally, these cords give rise to the terminal branches that control the muscles and skin of the arm, including the musculocutaneous, axillary, radial, median, and ulnar nerves. Some important branches also come off along the way, like the suprascapular, dorsal scapular, and pectoral nerves, supplying key shoulder and chest muscles. When we look at a peripheral nerve in cross-section, it's organized into three protective layers, each with a specific role in function and healing. At the most microscopic level, individual axons are supported by a delicate connective tissue that maintains their metabolic environment and shields the nerve fibers themselves. These axons are then grouped into bundles or fascicles, which are wrapped by a specialized cellular layer that preserves fascicular structure and forms the critical blood-nerve barrier. Surrounding everything is a tougher outer layer that holds the nerve together, protects it from mechanical stress, and carries the blood vessels supplying the nerve. From a clinical perspective, the extent of nerve injury depends on which of these layers is disrupted. Preserving the fascicular covering is especially important, as it is associated with better surgical outcomes. Understanding this layered anatomy directly informs operative decisions, including whether neurolysis is sufficient or whether nerve grafting and more complex repair techniques are required. The brachial plexus begins with roots C5 to T1, which exit the spine and pass between the scalene muscles. Each root carries both motor and sensory fibers. C5 powers elbow flexion, C6 extends the wrist, C7 controls the triceps, C8 flexes the fingers, and T1 manages fine hand movements. Key branches like the dorsal scapular and long thoracic nerves emerge here. These roots unite to form the trunks of the plexus. Clinically, root injuries produce predictable patterns of weakness or numbness, and avulsions require nerve transfers since they cannot be directly repaired. At the root level, key branches arise early, including the dorsal scapular nerve to the rhomboids and levator scapulae, and the long thoracic nerve to the serratus anterior. The roots then combine to form the upper, middle, and lower trunks. Injuries at this level cause characteristic motor and sensory deficits, and when roots are avulsed proximally near the spine, they cannot be repaired directly, making nerve transfers essential for restoring function. After the brachial plexus trunks form, each splits into two pathways. Think of these as flexor and extensor routes, one heading to muscles that bend the arm and hand, the other to muscles that straighten them. Under the clavicle, these pathways regroup around the axillary artery into three cords. The lateral cord supplies the muscles that flex the arm, the posterior cord powers the extensor muscles, and the medial cord contributes to hand movements, including the ulnar and part of the median nerves. Clinically, injuries at the cord level leave the upper roots intact but can still seriously weaken the arm and hand. These cords are also the preferred sites for nerve transfers, helping restore function when specific nerves are damaged. The brachial plexus ends in 5 key nerves, each controlling specific movements and sensations. The musculocutaneous nerve flexes the elbow, the axillary nerve lifts and rotates the shoulder, and the radial nerve extends the elbow, wrist, and fingers. The median nerve enables thumb and finger flexion for precision grips, while the ulnar nerve powers fine movements of the hand's small muscles. Each nerve also carries sensation from distinct areas of the arm and hand. Because distal injuries produce specific motor and sensory deficits, knowing these patterns is essential for accurately localizing nerve damage. Understanding the key anatomical landmarks of the brachial plexus is crucial, both for clinical assessment and surgical planning. The scalene triangle is where the roots and trunks of the brachial plexus emerge, making them particularly vulnerable during traction injuries. The clavicle region carries the divisions, which can be compressed and fractures. Fractures of the cervical spine can also lead to root avulsions. Beneath the clavicle, the cords wrap around the axillary artery, and high-speed trauma can injure both the nerves and the artery, potentially causing serious complications. In the supraclavicular area, the phrenic nerve runs along the anterior scalene. An injury here can cause diaphragmatic paralysis. The spinal accessory nerve lies posteriorly and serves as an important landmark in surgical approaches. The infraclavicular area is ideal for identifying the musculocutaneous nerve and performing Oberlin transfers, where fascicles from the ulnar or median nerves are redirected to restore biceps function. For surgical access, the posterior triangle provides a corridor to the roots and trunks, while the deltopectoral groove allows safe access to cords and terminal branches. Injuries to these nerves can vary in severity. A neuropraxia is a mild injury where the nerve remains intact and usually recovers on its own. A rupture involves a partial tear of the nerve, while a neuroma forms when a damaged nerve attempts to heal but creates a painful mass. The most severe injury, an avulsion, occurs when the nerve is completely pulled from the spinal cord, often requiring complex surgical reconstruction. Understanding both the anatomy and the type of injury is essential for planning treatment and predicting recovery, as each level, from roots to terminal nerves, can be affected differently, influencing both function and management. Most brachial plexus injuries happen because of trauma. Think of serious car accidents, high falls, or even injuries during contact sports that can all stretch or tear the nerves in the shoulder and arm. In newborns, delivery complications like shoulder dystocia can sometimes damage the plexus as well. Not all injuries come from accidents. Tumors pressing on the nerves or radiation therapy can slowly impair the plexus over time, and sometimes injuries happen in the hospital, during surgery, from how a patient is positioned under anesthesia, or even from an injection near the nerve. Recognizing how these injuries occur is essential because it guides how we assess and manage each case. Brachial plexus injuries can occur through several different mechanisms. The most common is traction, which happens when the shoulder is forced down while the neck bends in the opposite direction, or when the arm is violently pulled or caught in a high-impact accident. This is typical in car crashes, sports injuries, and even during complicated deliveries. Compression is another mechanism. Here, pressure from the outside, prolonged awkward positioning, or something inside like a hematoma or swelling can squeeze the nerves. Fractures that narrow the space around the plexus can also have the same effect. Some injuries result from penetrating trauma, like knife wounds, glass, machinery, or even gunshots, which can partially or completely cut the nerves. Finally, high-energy blunt trauma, such as a fractured clavicle, first rib, or a shoulder dislocation, can directly rupture the nerves or even tear them from the spinal roots. Understanding these mechanisms helps clinicians predict the type and severity of the injury, which is essential for proper diagnosis and treatment. Brachial plexus injuries can be classified in several ways, starting with which part of the plexus is affected. Upper plexus injuries involving the C5 and C6 nerves are known as herb palsy and often produce the classic waiter's tip posture. Injuries to the middle plexus around C7 mainly affect elbow extension and wrist or finger movement. Lower plexus injuries involving C8 and T1 are called Klumpke palsy, leading to a claw hand and sometimes Horner syndrome. When the entire plexus from C5 to T1 is damaged, the result is a flail, insensate upper limb. We can also classify injuries by how they happen. Traction is the most common, but compression, penetrating trauma, surgical or iatrogenic causes, and even tumors or radiation can damage the plexus. Medically, nerve injuries are described using the Seddon and Sunderland systems. In Seddon's classification, neuropraxia refers to a simple conduction block with no axonal damage and usually full recovery. Axonotomesis involves disruption of the axon while the surrounding connective tissue remains intact, so recovery is possible. Neurotomesis is a complete nerve rupture that requires surgical repair. When the entire plexus from C5 to T1 is damaged, the result is a flail, insensate upper limb. We can also classify injuries by how they happen. Traction is the most common, but compression, penetrating trauma, surgical or iatrogenic causes, and even tumors or radiation can damage the plexus. Medically, nerve injuries are described using the Seddon and Sunderland systems. In Seddon's classification, neuropraxia refers to a simple conduction block with no axonal damage and usually full recovery. Axonotomesis involves disruption of the axon while the surrounding connective tissue remains intact, so recovery is possible. Neurotomesis is a complete nerve rupture that requires surgical repair. When the entire plexus from C5 to T1 is damaged, the result is a flail, insensate upper limb. When evaluating a brachial plexus injury, timing is crucial. Deficits that appear immediately after trauma usually point to direct nerve damage, while those that develop later may indicate swelling or compression affecting the nerves. The mechanism and severity of the injury also provide important clues. High-energy trauma, like car accidents or major falls, increases the likelihood of severe or root-level nerve involvement. Careful symptom assessment is key. Clinicians document pain, sensory loss, and any specific muscle weakness to pinpoint which nerves are affected. Finally, associated injuries should never be overlooked. Cuts, stab wounds, bruises, or bullet tracks, as well as musculoskeletal or vascular injuries, can complicate the picture or hint at nearby nerve damage that needs attention. A focused neurological exam is essential to understand the extent of a brachial plexus injury. Motor deficits usually follow a pattern based on the level of injury. Upper plexus injuries, affecting C5 and C6, often result in weakness of shoulder movements like abduction and external rotation, as well as reduced elbow flexion. In severe cases, this produces the classic waiter's tip posture. Lower plexus injuries, involving C8 and T1, mainly affect the hand. Patients may have weak finger flexion and impaired intrinsic hand muscles, leading to a claw hand and difficulty with fine motor tasks. By carefully mapping these deficits, clinicians can pinpoint the injured nerves and guide appropriate management. Sensory changes are an important part of evaluating brachial plexus injuries. Patients may experience numbness, tingling, or complete loss of sensation, often following specific nerve or dermatome patterns. Upper plexus injuries typically affect the lateral arm and forearm, while lower plexus injuries involve the medial forearm and hand. Reflex testing also provides valuable clues. Weak or absent biceps and triceps reflexes can help localize the injury to C5, C6, or C7, respectively. Sometimes a few key signs can reveal a lot about a brachial plexus injury. For instance, if a patient has drooping eyelids, a constricted pupil, and less sweating on one side of the face, it usually points to a serious lower plexus injury near the C8 to T1 roots. On the other hand, if the shoulder blade sticks out, the rhomboid muscles are weak, or one side of the diaphragm doesn't move properly, that often signals an upper root injury around C5 to C6. It's also important to look for related injuries that may accompany a brachial plexus lesion, like a broken collarbone, a dislocated shoulder, artery damage, or a neck fracture. These clues help guide both diagnosis and treatment. Certain warning signs or red flags signal a more serious brachial plexus injury. A completely flail limb at presentation is one of the most concerning. The presence of Horner's syndrome or a winged scapula, which points to long thoracic nerve involvement, also suggests significant root-level damage. If there's no improvement after 3 months of physiotherapy, that's another red flag, indicating the injury may be severe. Finally, any evidence of vascular compromise, such as absent pulses or a limb showing signs of ischemia, requires urgent attention. Recognizing these red flags early helps clinicians prioritize intervention and plan timely treatment. Imaging plays a key role in evaluating brachial plexus injuries, and MRI is usually the first choice. It allows clinicians to clearly see the nerves, assess whether they remain intact or disrupted, and identify problems like neuroma formation. MRI also shows the surrounding muscles and soft tissues, helping detect complications such as hematomas or signs of root avulsion like pseudomeningoceles. For even greater detail, magnetic resonance neurography is now considered the gold standard. It offers high accuracy in detecting brachial plexus pathology and is especially useful for defining the extent and severity of nerve injury. In practice, ultrasound is often used when the nerves are closer to the surface or when examining infants. It's also helpful during EMG studies and can reveal structural changes such as scarring or nerve thickening. X-rays don't show the nerves themselves, but they provide important context. A broken collarbone or rib may explain how the injury occurred, and an elevated diaphragm can hint at involvement of the upper nerve roots. Electrodiagnostic studies play a crucial role in assessing brachial plexus injuries, especially when the injury is closed and not obvious on imaging. These tests help clarify both the severity and the level of nerve damage. Electromyography is most informative a few weeks after injury, once denervation changes have had time to develop. It helps determine whether the injury is complete or partial and distinguishes between temporary conduction block, axonal injury, and complete nerve disruption. Repeating EMG over time also allows clinicians to track nerve recovery. Nerve conduction studies complement this by evaluating how well motor and sensory signals travel along the nerves. They help localize the site of injury, detect conduction block, and provide valuable information for prognosis and surgical decision-making. Treatment is centered on getting the best functional recovery while minimizing pain and long-term complications. The exact strategy varies with the nature of the nerve damage and how the injury occurred, which is why early, careful assessment is so important. Waiting too long can limit available treatment options and outcomes. Care is delivered in a planned sequence. The patient is first stabilized, the injury is then fully evaluated, and definitive repair is considered at the right time. Following this logical progression helps ensure nerve reconstruction is performed when it can be most effective, supporting successful reinnervation and recovery. When a patient presents with a brachial plexus injury, the first priority is always safety. Life-threatening injuries are addressed immediately, and the affected arm is carefully supported to prevent further damage. Any related injuries, like broken clavicles or vascular issues, are also treated at this stage. Managing pain is equally important. Nerve-related pain is treated with medications that calm abnormal nerve signals, while tissue or inflammatory pain may need short-term anti-inflammatories or stronger pain relief. In severe cases, targeted nerve blocks can help, but they're used cautiously until the full extent of the injury is clear. After a brachial plexus injury, recovery often starts with careful, non-surgical strategies. The focus is on keeping the joints moving and flexible to prevent stiffness or deformities, while holding off on any strong exercises until it's clear the nerves are intact. Patients also learn practical ways to manage daily tasks safely, and supportive devices like splints can help prevent problems such as clawed fingers or wrist drop. Often, mild injuries improve on their own over a few months, but if there's little progress, surgery may become necessary to restore function. The way we treat brachial plexus injuries really depends on how the nerve was damaged. If there's an open wound, the priority is to check not only the nerve, but also the surrounding muscles, bones, and blood vessels. Clean cuts can often be repaired right away, while injuries from blunt trauma usually benefit from a short delay to allow scar tissue to settle before repair. Sometimes the nerve isn't completely severed, and careful monitoring can allow it to recover on its own. Closed injuries are usually watched closely, with surgery reserved for complications or if there's no sign of nerve recovery after a few months. This approach helps ensure intervention happens at the right time, maximizing the chance of regaining function. The way we approach brachial plexus injuries depends on how much the nerve is damaged. Mild injuries usually heal on their own with supportive care, like movement exercises and pain relief. Moderate injuries may take longer, and if there's no improvement after a few months, surgery might be needed. When the nerve is completely severed, repair is done as soon as possible for clean cuts or slightly later for blunt injuries, sometimes using grafts or nerve transfers. In the most severe cases, like root avulsions, reconstruction with nerve or tendon transfers and early rehab gives the best chance for function, though full recovery isn't always possible. Surgery is considered when there is clear evidence of severe nerve injury. Injuries involving root avulsion require prompt surgical evaluation because spontaneous recovery is unlikely. When a nerve is ruptured or completely severed, early repair offers the best chance for functional return. Surgery is also indicated if there is little or no meaningful recovery after several months of rehabilitation, or if symptoms continue to worsen, such as increasing pain or progressive neurological deficits. Surgical treatment of brachial plexus injuries can be divided into primary and secondary procedures, depending on the potential for nerve recovery. Primary procedures focus on rebuilding the nerve pathway and restoring muscle innervation. When a nerve is intact but trapped in scar tissue, releasing it can improve function. If the nerve has been cleanly cut, a direct repair may be possible, provided it can be done without tension. When there's a gap between nerve ends, grafts, often taken from the sural nerve, are used to bridge the defect. In cases of root avulsion, nerve transfers become essential. These involve redirecting working nerves, either from within the plexus or from nearby sources, such as the spinal accessory or intercostal nerves, to reinnervate critical muscles. In secondary procedures are considered when nerve recovery is incomplete or no longer possible. These aim to improve function using alternative strategies, such as transferring tendons or muscles to restore movement, stabilizing joints for better control, or performing free functional muscle transfers in late or complex cases. Together, these surgical options allow treatment to be tailored to the type, severity, and timing of the injury. Rehabilitation is a critical part of recovery after a brachial plexus injury and requires a long-term, multidisciplinary approach. It starts early, often immediately after injury or surgery, and continues for months or even years as function gradually returns. In the early phase, the focus is on preserving joint movement and preventing stiffness. Gentle range of motion exercises and appropriate splinting help avoid contractures, while proper support, such as slings or taping, protects the shoulder from inferior subluxation. Early, consistent rehabilitation lays the foundation for meaningful functional recovery. The outcome of a brachial plexus injury depends on several key factors. The type of nerve injury plays a major role. Simple stretch injuries tend to recover best, while ruptures have a more guarded prognosis. The most severe injuries, involving root avulsion, have the poorest potential for recovery. The level of injury also matters. Upper plexus injuries generally recover better than lower plexus or global injuries. Timing is equally critical. When surgery is needed, the best results are seen if it's done within the first few months. Delayed intervention reduces recovery potential as motor end plates gradually degenerate. Age further influences outcomes. Children, especially those with birth-related injuries, often recover remarkably well, while adults tend to experience slower and less complete nerve regeneration. Future advances are transforming how brachial plexus injuries are treated. Stem cell-based therapies aim to enhance nerve regeneration by supporting Schwann cell activity, promoting axonal regrowth, and releasing growth factors that improve repair. In severe injuries, newer reconstructive strategies focus on preserving motor neurons and encouraging spinal axon regeneration, which can significantly improve functional outcomes. Schwann cells remain central to these processes by providing both structural and biological support. For patients with irreversible nerve damage, modern bionic and myoelectric prostheses now offer functional restoration of upper limb movements, improving independence. At the same time, AI-assisted decision models are helping clinicians personalize treatment and optimize surgical timing. In summary, the brachial plexus is a complex network, but a solid understanding of its motor and sensory functions allows clinicians to localize injuries with confidence. This forms the foundation for accurate diagnosis, thoughtful surgical planning, and effective rehabilitation, directly linking anatomy to patient care. Treatment is always tailored to the individual, taking into account the type and severity of injury, timing, and patient factors. Ultimately, successful recovery depends on early recognition, appropriate intervention, and sustained rehabilitation over time. Thanks for watching. Don't forget to like, share, and subscribe to StudyNeuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.